ones we're going to talk about are the transposition of the great arteries and hypoplastic left heart. So the great arteries are considered the aorta and the pulmonary artery. And this is basically a condition where they have completely switched places. Right to left shunting will occur, and that's due to the two systems being completely closed. So the pulmonary system is not talking to the circulatory system whatsoever. And just like with the tetralogy patients, these type of patients, their survival is depending upon where their defect is, and that's staying open. So here's the picture. And you can tell how the aorta and the pulmonary artery have completely switched places. This heart, as you can tell, is almost completely purple, a mixing of the oxygenated and unoxygenated blood. So, not only are these patients looking pale and blue because they have mixing of blood, but they're also going to have some pulmonary issues. And you can tell with this particular one, they have an ASD, or an atrial septal defect. There's this hole between the two atriums. However, these kind of patients could also have a VSD. It doesn't have to be always an ASD. There just has to be some defect along the heart that's helping this patient stay alive. So in this situation, this ASD is keeping this patient alive because there's the mixing there to go out to the pulmonary arteries. Yes.
So you have to have a defect.
Or you're incompatible with life.
Or you're, okay.
Right.
So is that what that is showing on the top, the PID?
This one, they also have a PDA, yes.
Or PID?
But I would kind of ignore that one because this is the main one that's keeping them alive right now.
Okay.
Right, so as far as manifestations go, these patients are in cardiomegaly. Newborns are going to look very cyanotic, very blue, very pale. They're going to be hypoxic, and that can lead to respiratory acidosis. They can also have signs of congestive heart failure. They're going to have very rapid respiratory rates and have difficulty with breathing. Similar to tetralogy of Fallot, we're going to give them prostaglandins in order to keep that ductus open, that defect that we looked at earlier. Because again, that's keeping this patient alive, and that's going to increase their oxygen circulation. We can do corrective surgeries in the first few weeks of life, and that's literally taking the aorta and the pulmonary artery and switching them back to where they should be. So it's a very extensive surgery, and most of the time as these children grow, they're going to require multiple surgeries. Their heart's enlarging. Some of those sutures that may be holding before may not be holding as well, so they're going to have multiple surgeries. The next mixed defect is called hypoplastic left heart, and basically that's an underdevelopment of the left side of the heart, particularly the left ventricle. So as we've been talking all morning, the left ventricle is the one that's the powerhouse, that does all the work, that's the strongest. So as you can imagine, if your left ventricle did not develop properly when you were in utero, you're going to have some major issues. As a result, this can also cause some aortic atresia. These babies are going to look very blue. This is almost when they're born. It can be a medical emergency due to their low oxygenation. They can have abnormally, obviously if there's an underdeveloped left side of the heart, then they're going to have a normally small left ventricle. They can also have a small aortic arch. The right ventricle, as a result, is going to have to work overtime since the left ventricle is not well developed, so you can have hypertrophy of the right ventricle. And usually, these patients don't have a very good prognosis. So here's the last picture of your hearts there. As you can tell, here's the left ventricle, and it's very poorly developed. And so the right ventricle, you can tell it's a little enlarged, has to work overtime. So you have right ventricular hypertrophy. And as with our other heart conditions, this patient has an ASD, or a defect between the two atrias, and that's what's keeping this patient alive. when we talk about the aortic atresia, you can tell how narrow and thin this aorta is as a result. And this particular patient also has a PDA. If you look up here, there's an opening between the pulmonary artery and the aorta. So those two defects are keeping this patient alive. So as you can imagine, if you have a small left ventricle, you're not getting the right amount of blood going through your circulatory system. So you're going to have some respiratory symptoms. You're going to have weak pulses. If that PDA or if the ASD closes, then these patients are going to go into cardiac failure very quickly. That's what's keeping them alive. So just like with these other conditions, we're going to give prostaglandins to keep that PDA or ASD open. As far as the left ventricle goes, you can't grow someone a new left ventricle, so you actually have to do a heart transplant in this situation. There's not a stent or a balloon or dilation or anything like that we can do for these patients. They need a completely new heart. Right, an infant who has congenital heart defect comes into the clinic with irritability, pallor, and increased cyanosis that began quickly over the last 30 minutes. As the nurse assesses the infant, the parent asks why the child's color is bluish. The best response by the nurse is the baby's skin color is you guys think A, B, C, or D?
C.
That's right. Alright, so real quickly we're going to touch congestive heart failure. Very similar to adults. If you have right-sided failure, that's due to the pulmonary artery. We're not getting enough blood pumping through there, so you're going to have systemic effects, meaning you're going to have the typical what you think of with an adult, the large jugular vein, different types of pulses, that sort of thing, hypertension. With the left side of the heart, we're not getting enough blood through the body system, the circulatory system. So we're going to have a backing up of blood into the lungs. So we're going to have lung kind of symptoms, respiratory symptoms. We're going to be congested. We're going to be tachypnic. These are those adult kind of patients that have to sit upright in a chair to sleep and that sort of thing. So when you think right-sided, we've got a backing up into the systems of the body. We're edematous. We have the big jugular vein, hypertension, etc. When you think left-sided failure, you're thinking that it's backing up into the lungs. So you're going to have pulmonary symptoms. So our heart tries to compensate, and we try to increase our heart rate, and we try to increase the force of each contraction with each heartbeat, and we also cause peripheral vasoconstriction. But as we know, eventually the heart cannot continue to do this, and so you get complete congestive heart failure, both right and left-sided. So as far as signs and symptoms go, similar to adults, you have pulmonary congestion, systemic congestion, and also impaired function and pumping.
The heart is a beating muscle that pumps oxygen and nutrient-rich blood to the body via the circulatory system. Inside the heart are 4 chambers, which collect blood and then redistribute it to the lungs and body. Several conditions can impair the heart's ability to effectively circulate blood. Defects or diseases of heart muscle or valves can cause failure of the heart to maintain an adequate blood circulation. Coronary artery disease, high blood pressure, or narrowed or clogged arteries can compromise the blood vessel's ability to efficiently deliver blood, thus increasing the workload of the heart. Any of these conditions can result in an enlarged heart with compromised function. Eventually, the failing heart cannot pump out the amount of blood that is being delivered to it. This causes pressure to build within the heart chambers and venous system, resulting in an accumulation of fluid in body tissues. This progressively worsening series of events is called congestive heart failure, CHF. As CHF progresses, swelling or edema often occurs in the legs and feet. Fluid may also collect in the lungs, causing shortness of breath. Eventually, heart failure may affect the function of the kidneys, further increasing fluid accumulation in the body and causing additional work for the failing heart. CHF is a chronic condition with reduced life expectancy. In the case of valvular defect, surgical intervention may be required.
So in order to diagnose CHF, we're going to look at the clinical symptoms. Are they displaying right-sided heart failure symptoms, or are they displaying left-sided? We can also do chest x-rays. We're going to look at see how big the heart is, cardiomegaly, because it can fill up with fluid. Also, there can be hypertrophies from the working overtime. We look at increased pulmonary blood flow. We can do ECGs to detect ventricular hypertrophy from the ventricles trying to pump hard enough. They can also do echoes. Usually, in this video, it showed that CHF is caused by coronary artery issues, and that's not the same with children. Children, it's usually going to be congenital problems or just poor functioning with electrical issues. So in order to treat CHF, we're going to give digoxin similar to what we give with adults, and that's going to increase the cardiac output. We're going to try to decrease that cardiomegaly or that heart size. We can also give ACE inhibitors, which causes vasodilation. We can give beta blockers, which usually aren't used widespread. It's more with specific patients, usually the older patients. And that's going to cause vasodilation as well, and try to decrease that heart rate and the blood pressure. As far as the fluid goes, we're going to give diuretics. We're going to put the child on fluid restrictions. We can do things like Lasix or Diarrhea. We're also going to try to decrease the cardiac demands, which are things like bed rest or playing in the bed. We want to put them in a semi or high Fowler position, and why is that? I'm sorry?
It like helps with the pumping or releases workload or whatever.
Right, it helps with the respiratory distress and the heaving, trying to catch your breath. We can also give these patients oxygen to help with low oxygen levels. So we're going to talk a little bit about digoxin because it's, if you remember, it has that very narrow therapeutic range. So we have a lot of education to do with parents when the patient goes home with digoxin. If a patient that is an infant and if their heart rate is less than 90 to 110, we're going to hold the ditch dose. We're not going to give it. If it's a younger child and it's less than 70, then we're going to hold the ditch dose and not give it. If you remember, with adults and with kids, you don't want to just check the radial pulse for a minute. You want to check the apical pulse because a lot of these kids have different dysrhythmias going on, and that apical pulse will be different from the radial pulse. So you want to listen for a full minute, the apical pulse. So these patients and the parents actually get sent home with a stethoscope so they can listen and they're taught how to check that pulse correctly. We also want to teach them about the narrow therapeutic range and the toxicities, which are the bradycardia, dysrhythmias, nausea and vomiting. We teach these parents how to use a dropper. Sometimes they don't understand exactly how that works. We also have to teach them how to calculate the dose, how they give it every 12 hours. If they miss a dose because they just forget or they were out or something happened, we want to remind them not to give an extra dose. One more thing, again, is just having them learn how to check the apical pulse and to return that demonstration before that their patient's discharged so they fully understand how to give ditch and the consequences of what a side effect looks like from ditch. 2-month-old child has a known cardiac defect and is in congestive heart failure. Which assessment finding indicates the nurse a toxic dose of ditch? Briefly, we're going to talk about the different cardiac disorders. There's 3 of them that we're going to discuss, and that's endocarditis, rheumatic fever, and Kawasaki's disease. Usually these disorders occur at birth, and a heart that's either normal before or they can be a congenital heart defect that's already happened. So if a patient is born with a congenital heart defect, they're going to be more at risk for developing bacterial endocarditis, rheumatic fever, or Kawasaki's disease. Endocarditis is a bacterial